Good morning, everybody. My name's Kathryn Crawford. I'm one of the physios from the Royal, and really what I would like to do today is just to give you a bit of an insight into how their cough is affected in motor neurone disease, and then to have a little look at the role of respiratory physio and what we can offer. So really the objectives over the next half an hour or so, I think to appreciate what happens in motor neurone disease, we actually need to first of all look at what happens when we normally cough. So we'll have a quick look at that. We then will consider what actually happens in this disease process, how we as physios can assess this, and then our different treatment options. And I know the word cough assist is bandied about an awful lot, but there is actually other treatment modalities that we can initiate sooner in the disease process. So it's just to raise the awareness of what else we can offer. Okay, so let's have a little look at a normal cough first of all. So we all cough. Probably have heard it numerous times this morning. So we all do it. We probably do it subconsciously. We're not even aware of what we're doing. But actually in a normal cough, there are three phases to it, okay? So the first phase is our inspiratory phase, okay, where we use our inspiratory muscles. We take a deep breath in, okay? We will generally inspire up to about 85 to 90% of our total lung capacity. So we do get quite a good amount of air in there. We then will have a compression phase, and this is quite vital for a good strong cough. And it's where the glottis will close for a very short space of time, so 0.2 of a second, but that's essential to build up your intrapleural pressure to get enough force behind it. And we then have the expulsion phase, and that's where we use both our abdominals and our intercostal muscles to cough out, okay? And needless to say, reduction of any one of these factors can lead to an ineffective cough. So just to sort of highlight, might be an irritant, it might be secretions in the chest, could just be normal secretions, or it could be an infection, something there. Inflammation will irritate the airways. As I say, we take a deep breath in, we get that tiny little amount of compression, and then we will have the expulsion phase where we do cough out. So what happens in motor neurone disease? Okay, all three phases may be affected. So we can get inspiratory muscle weakness, we can get expiratory muscle weakness, which will obviously affect those two phases. We also unfortunately can get bulbar impairment. So if they lose that glottic glottic control, again they reduce the pressure that's available to drive their cough forward. And really an effective cough goes again without saying. We really need that just to minimise the development of lower respiratory tract infections, and ideally then to reduce hospital admissions. So I thought actually at this point we might have a little bit of audience participation. Okay, so just to say, if anybody has any colds, coughs, any airborne contagious disease, please refrain from doing this. But I want everybody in the room to take a nice big deep breath in and give me a really good strong cough out. Music to my ears. Okay, this time, and we just want to give you an insight as to what these patients feels like. I want you to take a really shallow breath in. I want you to let your tummy muscles go really floppy, which is quite hard because it's an automatic reaction, but try as best you can. So a nice shallow breath and a okay, obvious difference, all right? I now want you to picture the worst chesty cough, chest infection, maybe pneumonia that you've ever had, okay? Imagine what it felt like for those secretions to be sitting there. And that second cough is probably your cough on a good day, okay? As you can see, really unpleasant sensation. It's irritating the airways, it's making you cough, and that's really all you've got there to deal with it. Not only is it really unpleasant, it can be extremely exhausting. So these patients are coughing and coughing and coughing and really trying to clear whatever they can. It's also very distressing. Both for the patient and for their families. So the amount of patients and families that'll say to me, I think I'm going to choke on these secretions. I think I'm not going to be able to clear them. And families watching their loved ones having to try and cough and clear these secretions, again, can be totally distressing. So how do we as physios actually look at this? So we can take each phase separately. And look at it. So we can look at the inspiratory phase, and we use lung function for that. So I'm not going to go into too much detail on that, but we can use vital capacity. We can also look at the mean inspiratory pressures, and as soon as we notice those dropping, we then can try and support that phase, and I'll go into our treatment options in a moment. We can also have a quick look at how the glottis is functioning, and I made a really quick simple assessment of that. Is if I take a deep breath in, and I get the patient to say E, 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 E. It should be nice and distinct, okay? So they should be able just to close that glottis each time and give me a nice clear E. If it's somebody with any sort of bulbar involvement, they'll take a breath in and they'll go E, and they can't get that nice succinct little sound. So it's a really quick assessment just to sort of give us an idea as to if anything is involved there or not. We can then look at the expiratory phase. We can use, again, lung function with mean expiratory pressure, but we use what's called peak cough flow a lot, and I'm just going to go into a little bit more detail about that. So again, with using it, I'll also listen, and again, a lot of you, if you actually listen to the patient's cough, you do get a lot of clues just by getting them to cough in front of you. So obviously, as I say, the audibility, so you saw the difference in whenever you could do a deep breath in and the strength and the sound of that cough. The flow of the cough, so a lot of patients, we need one good strong cough to clear. A lot of patients will actually try and mimic that by doing lots of little coughs, so they'll go thinking that that's going to be effective. Obviously the sound of the cough, and we do need to remember that these patients may have other comorbidities, they may have underlying existing lung disease, so we may get wheeze associated with that, so there may be other things that we need to look at when we're listening to that, and as I say, the quality. And so really then, as I say, as a measurement, we use peak cough flow. So what is peak cough flow? It's a very simple assessment tool. We have a peak flow meter, and we either have it connected to a face mask or to a mouthpiece. And again, sort of the patient's ability to seal might be the deciding factor as to which we use. I personally like to use face masks. I think it's quite hard to cough into a mouthpiece, but some patients do prefer it. This is simple. This is something that they could actually have at home, that a patient or carers can even have, just even monitor how their cough is, especially if they think that things are deteriorating. So how do we do that? We get a position that's comfortable. So for most of them, it'll be in sitting. Some people, if sitting even is getting quite difficult, we might sort of have it half lying. We get them to take a deep breath in. We do apply the mask quite firmly, and we get them to cough as hard as possible into it. So our normal peak cough flow, if we were all to do that today, it would sit somewhere between, say, 360 up to 840 litres per minute. Okay, and that's just dependent on size and shape and things like that. The BTS then gave us some nice guidelines back in 2009, and this was generally a neuromuscular disease, not motor neuron specific, but they were basically saying that peak cough flow should be measured routinely and also at the time of an acute chest infection, okay? It really does reduce quite significantly when these patients do get a chest infection, so again, it's looking at that. They came up with a couple of levels, so basically when your peak cough flow drops below 270, that's when we need to start assisting it and actually trying to raise that cough so that we're getting it sitting about there so we have an effective cough. But we've also identified through lots of different research studies that actually we need a peak cough flow of 160 or above to actually be able to clear secretions. So for effective chest clearance, we do need to be hitting that level. And that's when, if it drops below that, we do try and put in additional strategies. So the NICE guidelines, which were published last year, gave, which were specific for MND, again, were along the same lines. So again, if somebody has an effective cough, and I'll go through these treatment options in a moment, we can either consider unassisted breath stacking or manually assisted cough as our first line of treatment. Okay, for anybody that does have bulbar dysfunction or whose cough is becoming more ineffective, we'll consider assisted breath stacking, and again, I'll show you that. And then it's also considering the mechanical cough assist if breath stacking becomes ineffective. So there's simple sort of suggested strategy as to when we should implement each of these treatment techniques, and that's sort of, I think, where early detection, early identification is crucial with regards to physio in these patients, because we can initiate a lot of these treatment techniques sooner rather than later, rather than having to get to the stage where they do need cough assist. So really, if you can manage a peak cough flow above 270, generally they're sort of thinking you might only need a bit of assistance and assisted cough when you are unwell, so when you have a chest infection. If it drops, but we're still sitting okay, we're still sitting about the 240, 245 kind of mark, we might either put in some bit of breath stacking or a bit of manual assisted cough, depending on which phase of the cough is affected. We might then try and sort of supplement that. If it drops down a bit further, we'll then look at combining those techniques. And then, as I say, when it gets to the 160 level or below, that's when we will look at cough assist. Plus or minus a manual assisted cough, and sometimes, especially if they're unwell, we will need to coordinate those. So we'll just have a little look at what these treatment techniques are, as I've used all these names. So breath stacking or air stacking, again, it's a non-invasive technique, and we basically use it to try and achieve the patient's maximum insufflation capacity. And what we mean by that is we want to get as much air as we can into these lungs to really be able to drive that cough, okay? We use a manual resuscitator bag. It's got a one-way valve. So basically what we can do is we can stack the breath without losing any air back out again, okay? So as I say, we can either do a series of stacked breaths. So what we would do is the patient would take a breath in. We'll use the resuscitator bag to supplement that. They'll hold that. They'll take another little top up, another sort of little breath. We'll again supplement that, hold it, and we could do that 2, 3, 4 times until they say, that's me, that's as much air as I can get into my lungs. To do that, though, we do need to have some glottic control. So stacking the breath is great when we do have glottic control. If we don't, then what we can do with the resuscitator bag is actually just single breaths. So it's just one big breath in, and then they'll either breathe out or they'll cough. Sometimes when we don't use it, so I'll not go through the list, but it's there, normal kind of contraindications with positive pressure. Picture there just of sort of showing how it's been done. We have used 2 physios in this picture. A lot of the time, though, this can be done either by the patient themselves, if they've still got good hand and arm function. And I actually, even if they don't, what a lot of patients will do is actually use a mouthpiece, and some of them, they're all very ingenious. They'll have it in between their knees and they'll squeeze the bag like that. We had one lady that we got additional tubing for, and so she actually sat and used it under her foot and could stack her breaths with the mouthpiece. So really the patient can use it themselves, or as I say, it's quite an easy technique for family members as well to use. What we generally do is there's a couple of options for us. So if it's purely for chest clearance, we'll do a series of these breaths and then get them to cough. But what we do find as well is with these patients, especially if they're not getting full inspiration, is their chest can get very stiff. And so we really want to try and sort of improve their pulmonary compliance, give that chest wall a nice stretch and open up any sort of areas of collapse. So sometimes we'll just use it just to really try and kind of improve that as well as chest clearance. So generally kind of twice a day we will get these patients to do a series of these breaths, as I say, whether it's just for that nice sort of stretch and to keep everything, all those airways nice and open, or for chest clearance as well. Going on then to manually assisted cough. And basically what that is, it's a manual pressure that we will give to a patient. It's either in line with the ribs or into the abdomen, okay? And we can increase their peak cough flow by increasing the airflow and also intrathoracic or intra-abdominal pressure. And they've looked at this, and obviously a combination of both thoracic and abdominal pressure does produce a greater change in peak cough flow. So as I say, we can combine that with breath stacking or with cough assist to try and maximise everything. Again, a couple of times when we don't use it, or some precautions. So again, if there's pegs or rigs, we might just need to change where we actually put our hands and sort of work around that. So what does it look like? Okay, so with the patient, we will use our hands. We can use them either centrally, we can go more out to the side, we can use the forearm actually to get a nice kind of pressure in on the abdomen. Again, sometimes it will be a 2-person technique, more generally when they are unwell, so when they're in hospital and they have lots of secretions and they're very difficult to clear, we may need to get another physiotherapist in to really try and help to clear these. But it's just to sort of show you the different options. And again, some family members are very good at doing them. They get very practiced at it, and they can really sort of work well with it. Moving on then just to cough assist, or mechanical insufflation exsufflation is the technical term for it. So it's a non-invasive, again, respiratory aid. So it augments both flows, so your inspiratory flow and your expiratory flow. And what it does is it uses positive pressure to first of all inflate the lungs, and then we have a rapid shift to a negative pressure. And when we do that, we get a shearing force and we can move the secretions more centrally and ideally sort of up to the mouth. When do we use it? Okay, so generally we will bring in cough assist when the peak cough flow does fall below 160. Okay, they have looked different research studies about introducing it earlier. So should we introduce this when things are higher? And they compared it with breath stacking and manually assisted cough, and really they found there was no benefit to introducing it earlier. We were getting the same effects with breath stacking and manually assisted cough. And obviously there's a cost component with that. So again, it's getting it at the right time. We can use it either via face mask, a mouthpiece again, or we can use it with an ET or trachea if need be. We can use it in manual mode or automatic. So generally, whenever I'll see a patient, we will use the manual mode to set the pressures that we're going to give, maybe have a little look at the length of the breath that they need, the length of the cough out. We'll then set them up a program, which is an automatic mode. And generally, they will go home with that. Really takes, again, the pressure off any of the families. So they hold the mask or they hold the mouthpiece and they press start and stop. And that will run through a cycle. Generally, we'll have a cycle of maybe sort of 4 or 5 breaths, and on the 5th breath or 4th breath, it'll give a cough out. And so we open up those airways and then we give a nice sort of cough. And again, we can guide on how many cycles and how many times a day that we're doing that with. So once it's set up, as I say, we can lock the settings as well, so they can't be playing around with it. And generally, the families do find it quite easy to use and quite user-friendly. As I say, we use it acutely in the hospitals, but more so as well, we are trying to get it more out into the community for these patients to have access to. The pressures we can go to is up to about 60 centimetres, which might seem like a lot. But again, I personally have maybe never quite gone that far, but I have gone up to quite high pressures. And again, as their disease progresses, sometimes they do just need that increase in pressure just to really clear those secretions. So again, we really want to set the insufflation pressure so we can get as much air into those lungs as possible. And then we will set sort of an expiratory flow bias, which helps to move those secretions. Again, just the guidelines back in 2009. We're recommending cough assist for anybody that was unable to increase their peak cough flow to an effective level with the other strategies. So really important that we do get these patients early, try these other strategies, keep their chest nice and compliant, so then when we do need to introduce cough assist, it is effective. Okay, so again, settings, they really do need to be individualised from each patient, and this is where a good sort of thorough assessment, I normally will take at least 2 sessions with each patient, getting them used to the machine, getting their settings, and then getting them used to it, and really looking at length of breaths and length of cough and all those different factors that we can do with it. Size and shape may require higher pressures. We used to think, and sorry, I probably should have just altered this slide slightly. We used to think that we would need higher pressures for some patients who have got bulbar symptoms to try and sort of overcome the loss of glottic function. There's actually been a bit of research done recently where they actually took video imaging and they looked at cough assist and what actually happened to the glottis when we did give them higher pressures. And actually in quite a lot of these patients, we were actually causing their vocal cords to adduct, so to close over. So actually cutting off their airway. So again, it's maybe looking at giving them less pressures, but over a longer sort of breath. So there's lots of things out there that we really need to be looking at and really trying with these patients. It's ever evolving, and that's what we're finding when they are looking at different aspects of it. Because of that, Cochrane review back in 2013 basically said they don't have enough evidence to guide kind of clinical practice. And again, they don't have enough evidence to support it or for against it. A lot of the studies that are out there, unfortunately, they are quite small. They are more observational studies, so it's very hard to draw conclusions from them. Certainly in clinical practice, we do find it very effective. And a lot of these patients, again, will say thank you. That has really just helped to clear these secretions. It's taken that fear and that anxiety aspect out. They know that they have something which they can use. There is, though, more recently, a protocol for a Cochrane review has been proposed to actually look at the assess of the effects of MIE and breath stacking, specifically in MND, not only in reducing morbidity and mortality, but also enhancing quality of life. So it'll be quite interesting just to sort of see where that comes from. So where are we at in Northern Ireland? I hate to end on a negative note, and hopefully that has given you some insight into what we can offer these patients, and that there are lots of treatment modalities out there. Unfortunately, there isn't any funded dedicated service for respiratory physio and MND at the moment. So a lot of these patients may be introduced to these techniques as inpatients, so whether they're in with a chest infection or potentially even in getting a rig or a peg inserted or for some other reason, and it'll be picked up along the way that actually their peak cough flow is dropping, that this is becoming more of an issue. Community palliative care teams, the hospice team, they may introduce breath stacking, manually assisted cough as appropriate. Unfortunately, they don't have access to cough assist at the moment to try. I know the hospice do, so they're certainly coming on board with that. Myself, the respiratory physio in the Royal, I can assess patients as outpatients for this. But it's on an ad hoc basis. This is something that's maybe just evolved over the last sort of few years. I see respiratory outpatients. I set inpatients up on cough assist. Oh, will you see this patient? But I also carry a completely different caseload. So numbers are increasing, capacity is limited. So we are needing to actually look at our current practice and what we're going to do, and potentially need to restrict it to Belfast Trust. Because I can't see all the patients from around the province, unfortunately, as I say, or hopefully actually getting an MND clinic sort of set up. Again, what we also find is provision and access to cough assist then is very variable across Northern Ireland. It's more depends on who you're linked into, who can get it, who will order one, what budget it comes out of. So there's lots and lots and lots and lots of issues to do with that. And that's what a lot of the physios out in the communities are saying, that they're happy, they could set it up, but they just cannot get the machine. So we do need to look at that, and we do need to streamline it. So, and again, I think we're going to leave questions to the end. Thank you.